Good morning. Morning, everyone. Yeah, we are about to start, and our guests are here, and we thank you all for coming. I hope you've had your breakfast, and now we are ready to launch documents that you'll get to know about. But before we start, I'd like us to stand up and sing the national anthem, the East African and Kenya, and then we'll have the prayers. Can we all stand for the national anthem? It will be played and you can see it on the screen.
Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Thank you. I'll call upon Mercy Irene and Mohammed to come over and pray for us. Mercy.
Good morning. Let's arise, believe, and we pray. Our Lord and Father, we come before you this morning. We are humbled for the gift of life and for the gift of each one of us. We do not take it for granted for us being convened here, but we want to thank you for having us as a purpose to fulfill your mission for your population. We want to invite your presence. May you be with us, renew our strength, our wisdom, our knowledge, as we serve our populations and for the good of this country. In Jesus we pray and believe. Amen.
I'll pray in Arabic. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alameen. الرحمن الرحيم مالك يوم الدين إياك نعبده وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
Thank you. Thank you, everyone. Having honored God, we want to honor our guests, the representative of our Director General, Dr. Kibias, Dr. Mulwa, the Director of Medical Services, Preventive and Promotive Health, Dr. Salim, the Head Department of Primary Health Care, our guests from the counties, HENNET, that is Head of HENNET, Thomas Onyango, who is also the Country Director, Living Goods, Anthony Gitau, who is the Director of J&J Foundation, the Director, AMREF, Dr. Meshak Nderangu, Caroline Juguna, the Country Director, PATH, and Dr. Juliet Nabionga from WHO. Thank you very much for being here. And this is time for us to know each other and be welcome to this session. And we have come to launch documents under the Department of Primary Healthcare. And the head of department is here, Dr. Salim, who has been working very hard with the team on the ground to do the work that we are celebrating today as we launch. So I'd like to welcome him so that he can welcome us to this meeting, all of us. So Dr. Salim, karibu.
Good morning, everyone. Habari ya asubuhi. Mko salama? Kama mko salama, tafadhali mwambie mwenzako karibu katika hili kongamano. Okay, thank you very much. Dr. Simon Kibias, who is representing the Director General, the Ministry of Health. Dr. Andrew Muller, our Directorate of Medical Services, Preventive and Promotive Health. Our esteemed county directors of health from all the counties. COG officials present. HENET, represented here by Thomas Onyango, who is also the country director, Living Goods. J&J Foundation, our good friend Anthony Gitao. The other partners under the umbrella of Community Health Unit for UHC, including Living Goods, Luala Community Alliance, Financing Alliance for Health, AMREF, Waki Health, and Thinkwell, PATH, their director, Caroline Njuguna, WHO, which is being represented by Dr. Julius Nabioga, UNICEF, World Bank, the Fourth Estate, all the esteemed, distinguished guests, invited ladies and gentlemen, welcome to this primary health care document launch. We are very happy and excited, especially more because of the engagement that we have had with most of you. We are very encouraged, and we believe that this is the way to change our health in this country for better. This is the best effective way for us to have health for all in Kenya, especially looking that we are using PHC to implement our UHC. So I think this fraternity, we have a lot on our shoulders, but we are up to the task, and I'm grateful up to where we have reached. So with this, I would like us to introduce ourselves so that we can know who is there. I will start with the desk on my right, extreme right. So please just tell us your name and where you're coming from and what you're doing.
My name is Joseph. I'm a technician.
Good morning. My name is Tabitha Rotich from Media.
Morning, Judith Omonde, Royal Media.
Good morning, Dr. Mala Moli, County Director Health, Nyandarua.
Good morning. My name is Dr. Dirango Anjuki, Country Director at AMREF. Very happy to be here. Thank you.
Good morning. My name is Caroline Agutu, the County Health Promotion, Mombasa County, representing the County Director, Mombasa. I'm glad to be here.
Good morning. My name is Morira Felix, Country Manager at Thinkwell, Kenya. Happy to be here.
Good morning. My name is Yvonne de Jong. I'm from KENYA-AFYA, and we're here to learn more about public health financing as we are supporting 11 counties.
Good morning. I'm Dr. Alan Owino, County Director of Health, Kitui County.
Good morning. I'm Jacqueline Gitti from Kisii County, coordinating community health services and representing the county director.
Good evening.
Mic, or is it the people using the mic?
Yeah, I said my name is Richard Kakuri. I'm the Director of Public Health, West Pokot County.
Good morning. Dr. Andakali is my name, the County Director of Marsabit. I think it's a great day and I'm happy to be here.
Morning, everyone. Irene Mwangi, representing Health Relief International.
Good morning. My name is Robert Indieka. I work for African Leaders Malaria Alliance. Thank you.
Good morning. My name is the principal. We've been supporting countries in the rollout of community scorecards, so we're super excited for the launch of the community scorecard guidelines here today. So happy to be here. Thank you.
My name is Julius Mbea from Luala Community Alliance, and it's a pleasure to see some of these come to fruition. Thank you.
Excuse me.
Yeah, good morning. My name is Frederick Mwendwa from Machakos County, coordinating community health services in the county. I'm here on behalf of the County Director of Health, Machakos. Thank you.
Morning, everyone. My name is Pauline Irungu, and I work for PATH as the Global Policy and Advocacy Advisor for Maternal, Newborn, and Child Health.
Good morning and Happy New Year. County Director in charge of Preventive and Promotive Health Services, Homa Bay County. My name is Dr. Adel Ottoman. I'm happy that we are on the road of UHC through strengthening primary health care. Thank you.
Good morning, Catherine Muindi, Media.
Good morning. I'm Dr. Juliet Navionga, the WHO country representative.
Good morning. I'm Tekla Lisa, Media.
Morning. Teresia Kariuki is my name, Director Public Health and Sanitation, Kiambu County. It's a pleasure to be here because I believe after the launch, I'm expecting to get a partner. We go back to Kiambu and do the same and continue implementing the UHC. Thank you.
Good morning. I'm Dr. Dahir Somo. I'm the County Director of Health Wajir.
Good morning. My name is Philip Mugari. I'm representing Medic. Thank you.
Good morning. I'm Mohammed Harad, County Director of Health, Garissa County, and I'm expecting these guidelines we will operationalize at Garissa County. Thank you.
Good morning. I'm Dr. Angela, President and CEO of the Financing Alliance for Health.
Yes, good morning. Augustine, Director, Preventive and Promotive Health, Samburu County.
I'm Samuel Ucheng from the media.
I'm Dr. Patrick Borwet, Director, Preventive and Promotive in Baringo County.
Morning, everyone. I'm Rachel Ndirangu with PATH, Regional Policy and Advocacy Manager. Really glad to see this come to this point. Thanks.
Good morning, everyone. I am Melissa Wanda. I lead the advocacy and policy work for PATH in Kenya. Happy to have all of you here and happy to see these documents being launched today.
Good morning, ladies and gentlemen. My name is Alex Irogo. I work for Amref Health Africa in Kenya. It's a pleasure to be here.
Good morning, everyone. My name is Alois Gikunda. I also work with Amref Health Africa.
Morning, Josephine Kenyanjui, Senior Associate, Path.
Good morning, everyone. My name is Patricia Kawuma. I work with Africa Health Business.
Good morning, Dr. Tindi Felix, Director Health, CIA.
Good morning, everybody. My name is Satoru Watanabe from PACD Japan. Thank you very much for inviting me here. Great.
Good morning, Dr. Bernard Mackenzie from Kwale County.
Good morning. My name is June Mwende. I work for Financing Alliance for Health. I support Nairobi County in strengthening community health systems. Thank you.
Good morning, everyone. I am Laura Nabwire, Country Lead at In Supply Health. Glad to see a lot of people from counties where we work with our CSTOC approach for community health volunteers. Great that we are launching this today.
Good morning. My name is Elizabeth Kipto, Director Public Health Nakuru.
Good morning, everyone. I'm Maxine Luta, and I work with Mtani Radio, representing the people Mashinani.
Good morning, everyone. I'm Dr. Marianne Washo, pediatrician Bomet, here on behalf of our County Director of Health from Bomet.
Morning, Elvis Mondaviro, Director of Delta Vet.
Good morning, everybody. Dr. Nancy Kagode, County Director, Medical Services, Trans Nzoia. Happy to be here.
John Wanyungu, Minister of Health, Kenya, Division of Community Health Services. Thank you.
Good morning. My name is Noah. Work with AMREF. Thank you.
My name is Grace with AMREF.
Good morning. Muhammad Mohammed, Division of Primary Health Services and Family Medicine, Ministry of Health.
Good morning. I'm Kenneth Munge. I'm with the World Bank Group.
Good morning, everyone. Dr. Maureen Kimani, Head Division of Community Health, Ministry of Health.
Morning, everyone. I'm Dr. Agatha Olago, Head Primary Health Services and Family Medicine Division.
Morning, everyone. Jaggy John, CPHO, representing County Director, County number 014, the famous one. Thank you.
Tell us the famous one.
Embu County.
Morning, everybody. I'm William Kandagor, County Director of Public Health and Sanitation, Elgeyo Marakwet.
Morning. Alim Sko is my name. I coordinate primary health care services, Kakamega County. I'm representing County Director Kakamega. I'm happy to be here.
Thank you. Good morning, all. I am Robert Wetoto from Bungoma. I am standing in for Director for Health Bungoma. I coordinate PHC Bungoma.
Yes, good morning, everyone. My name is Dr. Komo, Director Health Homa Bay, and the chair of all the directors in the country.
Good morning. I'm Kennedy Ombogo. I come from Migori, where I work as a director of public health.
Good morning, everyone. My name is Rosemary Muganda. I work for PATH as Regional Advocacy and Public Policy Director for Africa, and I'm also the current chair of the Board of Directors of HENET. Welcome to the meeting.
Good morning, everyone. My name is Anthony Gitao. I'm the Director for Global Community Impact at Johnson & Johnson for Sub-Saharan Africa. Nice to see you all.
Good morning, everyone. My name is Dr. Lilian Otiso, the Executive Director of LVCT Health. I'm really excited to be here and all the work that we've been doing together with the ministry. Thank you.
I think I'll remove this. Yeah. Good morning, everybody. My name is Thomas Onyango. I'm the Country Director of Living Goods Kenya, also doubling up as the Deputy Chair of HENET. So happy to be here and looking forward to an exciting discussion and, of course, the launch, which is a great day. Thank you. Thank you.
Good morning. My name is Monica Kagwema, Director Public Health, Meru County. Thank you.
Good morning. My name is Dr. Winnie Kanyi. I'm the County Director of Health from Murang'a County.
Good morning. I'm John Imbogo, County Health Director, Tharaka Nithi County.
Good morning, all. I am Dr. Josephine Ohas, Acting Director, Public Health, Laikipia County.
Of the area, very proud to have a lot of support from counties that are already practicing the primary health care, especially the primary health care networks. Beside the ones that have been mentioned here, or they'll give us the experiences, that is Migori, Makueni, Garissa, and Kilifi. I'm very glad to say Nakuru is also one of the counties that has really been implementing this even before we launched the document at their place July 2019. I also want to mention that Kakamega Director is one of the counties that currently used PHC to move the vaccination. They were actually around number 27. Now they're about 5th in terms of the number that they are vaccinated, putting into place the community health workforce and fraternity to help them to get to these people. So I will invite Gladys to come, please, and continue with the next session. Karibu.
Thank you, Dr. Salim. Let's clap for ourselves. Yeah, there are people online. I was trying to remind Daktari. So we may not be able to know all of them, but feel welcome, those who are online, and we'll continue with the program. So at this time, oh, sorry, I didn't introduce myself. I'm Gladys Mugambi. I head the Division of Health Promotion, Ministry of Health. So at this time, I would like to welcome Dr. Agatha Olago, the Head Division of Primary Healthcare, to give us the overview of the ACCE framework and the PCN guidelines.
Thank you very much, Gladys. So I'll just take us through the guidelines that we'll be launching today. 2 of the documents, that's the Primary Healthcare Network guidelines, as well as the Advocacy, Communication, and Community Engagement Framework for Primary Healthcare. I know it's quite a mouthful, but I promise you the document itself is quite simple and very easy to use. So I'll just start off by talking about the primary healthcare network guidelines. I know if you were in Mombasa, I think a number of us were in Mombasa a bit earlier in the week. During the launch, a very great event took place earlier in the week. That's the launch of the Universal Health Coverage Policy, as well as the launch of the Health Financing Strategy. And these are key documents for us, even as we go, as we're on the journey for attainment of universal health coverage. And the PCN guidelines come to actually illustrate a lot of what is happening and what will happen, especially in terms of service delivery. If you just proceed, sorry. So the PCN guidelines are mainly a way of implementing, they're actually a tool for implementing the primary healthcare strategic framework. We also have the UHC policy and the health financing strategy, which were launched in Mombasa earlier this week. Okay. Sorry, I think you can just proceed. So we have, those are the documents that have actually set the pace for why we developed the PCN guidelines. When we started talking about the PCNs, especially when you're talking about the service delivery model for primary healthcare, how can you make sure that universal health coverage actually gets attained? And that's where the PCN came about. And you had quite a number of meetings with the CECs, a lot of meetings with the county teams, trying to see how this would work. And it borrows quite a lot from what is already happening. Having the sub-counties in place and coming out strongly and having that facility autonomy in terms of enabling communities to play have a role in terms of the healthcare services that they're receiving. And that's why the PCNs were actually formed. It actually comes from what you're already practicing, some of the best practices that you already have in our counties. A lot of these ideas actually came from you, and a lot of these ideas are being already implemented within the counties. So the main objectives for establishing the primary healthcare networks are mainly because we needed to ensure that we have an integrated way, we have an efficient way of doing things. And that is why it was actually felt that we need to ensure that no one is left out. So starting straight up from the communities and linking these community units to the primary healthcare facilities, as well as linking things to the referral facilities. So ensuring that you're handling not only the preventive and promotive health services and the public health services, but you're also ensuring that that is catered for in terms of the health services and the medical services that are being received. So when you look at the PCN, it integrates the communities as well as the health facilities. So if you think about PCNs, you can't just look at only public health aspects, or we can't just look at only our medical services, especially since you're thinking of a preventive and promotive approach, and you're trying to consider that primary healthcare approach in order to achieve universal health coverage. We realize this is the only way we can ensure that we have everyone on board. So we need to ensure that you have an efficient and coordinated way of having both an upward and downward referral system, and that's why we really needed to have these PCNs in place. In the next slide, just defining the primary healthcare network. This is an administrative health region that is established to increase access to the primary healthcare services for patients, as well as to coordinate with the local facilities in order to improve the overall operational efficiency of the network. And they're defined to have a hub and spoke model. In the next slide, you'll be able to see a diagrammatic representation of that. And mainly it's just formed by having several community health units which are linked to those primary healthcare facilities. That's our health centers, our dispensaries, and thereafter to the referral, primary healthcare referral facility, which is a level 4 hospital. And this can be either the public facilities, and you're also inclusive, and you're saying that they can also be the private facilities, the faith-based facilities as well. So as we move on to the next slide, if you look at the establishment process, it will need having those coordination structures. So we need quite a lot of leadership, a lot of coordination from you as the technical heads especially the county directors, as the technical heads of what is happening within the county. It needs a lot of teamwork in terms of setting up these coordination structures. So working as a team, the technical working groups looking at primary healthcare all will need to think about not just there's been a lot of challenges in terms of verticalization and looking at one disease. So we need to think around integrating our efforts. So we are thinking about reproductive health and or maternal health care or child health care. We know that it starts right from the community. Yeah, when a woman does not go for her antenatal care, and it actually flows into getting late for going delivery for her antenatal care services, we know that that also plays an impact into the kind of delivery experiences that she has, and even the children that are born. So we know that what happens in the community actually plays a role into the kind of indicators that you're seeing for child health and maternal health. So it means that even as you're setting up the coordination structures for the PCN, we need to know what is happening in our communities. So it needs to also start with having a baseline needs assessment at the community level. We also need to know that we can be able to have an effective linkage of the spokes, which are our community health units and our level 2 and 3 facilities. So we need to mark all those spokes. And there's also a very big part that is played by having our healthcare workers, our healthcare providers, having outreaches into our communities. So not just waiting for people to come to our facilities, especially our level 4 facilities, our hospitals, but we need to know that you can actually reach the people within the community, and there comes in the place of the multidisciplinary teams. So there's that mapping of forming those multidisciplinary teams and orienting the healthcare workers in that new approach, a primary healthcare approach. So it means that even if I'm sitting in a clinic and managing a chronic illness such as diabetes and hypertension, I should be wondering why I'm getting so many patients with diabetes from this community. Is there something we can do within the community to prevent that? So that's why it's going to be really necessary to work together with our healthcare workers in our facilities as well. And afterwards, also the aspect of ensuring quality, especially at the community level. So that's why the multidisciplinary teams actually play a big role in terms of having those outreaches and knowing how we're actually improving the quality aspects, and also being able to review our data to ensure that we are providing quality care, and also having an efficient referral system as well. Can we ensure that everyone in a community can actually access emergency care when they need it? If I'm able to call from wherever I am, do I know which facility I need to go for emergency maternal care, or for emergency, if they need an emergency admission? Can we follow the processes to ensure that the services are provided closest to the people and when they need it at the right time? And also ensuring that you're able to monitor and evaluate what you're doing, and using that data for the necessary decisions that need to be made. So this is just a summary of the primary healthcare network establishment process. I think we'll be able to hear a bit more from what has been happening in Garissa and other counties as well in terms of the pilot for the PCNs. So I mentioned the multidisciplinary team. It really brings in a lot of working together, teamwork in terms of approaching our health. So we're thinking around, for primary healthcare, it's an integrated approach. So we'll really have to break out of our shells, thinking around trying to bring in interdisciplinary, multidisciplinary teams, trying to work across those cadre divides that we've had. So it means that even as you're going out as a team, to reach out to our communities, we are bringing along the nutritionists to think around how we can actually improve what kind of foods the children are actually eating in the community. How we can actually even have the agriculture team on board to ensure that we're making sure that you're planting the right crops. So it means that we need to work with in a multi-sectoral way. And this multidisciplinary team also brings about, we're also bringing in the aspect of the family physician approach. And this is, we're actually hoping that the family physicians will be leading the multidisciplinary team. I know we don't have so many family physicians yet, but it's a practice and a discipline that is actually increasing more. And it's mainly because they have a community health approach to care. They're also bringing in the aspect of the preventive and promotive aspect to family care. And these are the first point of first contact for a person with an undiagnosed health concern. And we're thinking they need to be there to also ensure that for cases which don't have to come to the highest level of care, we're able to handle them closest to the communities. For chronic illness, we shouldn't have to manage them at the highest level of care. They should be able to access a lot of the care closest to where they are. It actually eliminates quite a lot of the costs that come with management of chronic diseases. So the guiding principles in terms of having the primary healthcare networks, having increased access, availability of outreaches to the multidisciplinary teams, referral, increasing aspects of referral and improving that process, both upward and downward referral, having sharing of resources. So whereby you have a PCN and they have radiology services or lab services, we don't have to have every lab having a small lab, every facility having a small lab or having a CT scan in every small facility. Yet these are resources that can be shared across that network. So these are arrangements that have to be put in place. It means that we need to have an arrangement with even some of the private facilities. When you're thinking around public-private partnerships, we can have arrangements with some of the facilities regarding how some of these services can actually be accessed within the networks, and where necessary. We need to ensure that we create relationships, even as you're having this PCN's establishment, looking at results-oriented and performance-based work, and ensuring that we have accountability to the community and person-centered care. And a lot of the documents that we'll be launching here are actually targeting that. I think we'll be hearing a bit more about the community scorecard, so it's a part of it. Regarding finances, I know there'll be a lot of questions of what does it cost to have a PCN? What does it cost to have having a new network? And you know it will need a lot of investment at the outright. But it's true that we need to invest in primary healthcare. We can't run away from that. But you know that it's a long-term investment. We will not see the returns now, but it's something that we will see in a few years to come. And we've faced quite a lot of challenges in terms of financing primary healthcare. I think currently we have quite a lot of declining funds, as well as different structures. And we know that the PCN structure in itself is actually meant to ensure that the community is taken care of, that we have funding as well for the community health units, the primary care facilities. And this is mainly because those level 4 facilities should also be thinking around the area that they're in. They should be thinking about that catchment population in terms of not all the population that are coming there, their health needs, and how they can actually help to prevent a lot of the conditions that are coming to them. So the outside, right now, one of the first areas we're looking at is clinical care, quality of care. But you know, at the end goal, one of the areas that you want to target is actually the aspect of financing. And I think this is actually quite well elaborated within the PCN guidelines, as well as also the health financing strategy. So it also brings out some of the sources of funds that we can actually tap into. And one of the main areas that we need to consider is the aspect of ensuring that you're subsidizing the poor and the vulnerable. This is just mainly looking at the PCN, and we were able to do some work in costing. And I'm sure we'll be engaging you on some of this work even later on, and a lot of the discussions around financing in primary healthcare and financing for the PCN specifically. And this is just mainly looking at some of the PCN structure while we're doing the costing. So this just shows some of the structures and the population, the way we had projected some of the populations for the PCN. Next slide. So if you look at the next slide, it just gives some of the costs of the PCN by scenario. And what we're able to see, we've already made quite a lot of investments in healthcare. There's quite a lot of structures already in terms of PCN. So it just comes in. So that means it's actually different county per county. Whatever it will cost to set up this PCN depends on already what is existing. And you already have a lot of existing structures. So what it will cost, and a lot of these costs were actually about 60% were being contributed to by a lot of the human resource, a lot of the service delivery costs. So we already have a lot that is ongoing, and it just needs a bit of a boost to let that thing, let whatever work is there going. And I think that's the part that we can play, putting in that coordination, putting in that boost, and putting in the structures that are required to get these PCNs going. And we did some costing study as well, I think with support of one of our partners. And what we're able to see, it actually, when it comes to the requirements that we need to invest, on average, I think in the country, we need at least to invest at least 3.7 times more money than we are investing currently in primary health care. About 4 times more than we already have there. So we already have, as much as we are doing quite a bit even within the primary health, we still need to put in more in terms of investment and ensure that even as you're putting in more, we're able to use it well. We need to be efficient in terms of what you're putting in terms of a human resource. How are we utilizing the health workers that we have even within the facilities? We know that a lot of the primary care facilities are quite underutilized, and they could actually do a lot more at that level and take up a lot more primary health care services that are being, work that is being done within the county. So that was mainly just summarizing a lot of the end goal in terms of financing and how we really hope that the PCNs can actually support financing, especially for the community and the primary healthcare space. So I'll just go straight into the advocacy, communication, and community engagement framework for primary healthcare. And this document just mainly gives us the goals, objectives, why we need to talk about primary healthcare and the primary healthcare networks. And if I could tell you, it's more of a cheat sheet. So if you need to know more about PCNs and PHC strategic framework, it gives an outline of what those documents mean. So we know that we need appropriate communication, we need appropriate advocacy in terms of primary healthcare, and this is key in terms of our efforts to improve primary healthcare. So it's actually helping us in terms of the reorientation and strengthening of the primary healthcare system. We need to bring in the multi-sectoral, we need to have a multi-sectoral action and approaches to address the social determinants of health. So that's what the SECE framework addresses. And we know that advocacy, we need to ensure that we map who we need to talk to, at what levels, who do we need on our side in terms of ensuring that we have primary healthcare. How do we set the stage for primary healthcare? When it comes to communication, just that we know that there's quite a knowledge gap in terms of what primary healthcare entails. We know some of the challenges that are in system as mainly because of what we've been facing in terms of the funding, and these are messages that we can actually use to address primary healthcare and raise awareness of primary healthcare to all stakeholders. And community engagement, we really need that. We need to start from the communities. We need to start from the households, ensuring that we have everyone on board as you're talking about primary healthcare. There's a lot that can be done from the household, and I think we've learned that from the COVID pandemic. There's a lot that has come from just hand washing and ensuring that we have clean environments. So there's a lot that can happen from there, and this is what we need to take forward in terms of talking about primary healthcare. So a lot of the challenges that we've faced, and that's what made us work on this advocacy, communication, and community engagement framework. There's quite an information gap, a large information gap on primary healthcare among leaders, community, and policy makers, yet they're the ones who play a big role in terms of how we get our primary healthcare services funded, the inadequate resources for health communication, and just that prioritization that is being given to health communication. We're in a forum with health promotion officers, and they're really saying how no one thinks it's important. Yet that messaging is quite a big part in terms of how uptake of vaccines and how uptake of some COVID measures have been taken up. Inadequate human resource for health communication, weak communication channels, and community engagement. We also have some ineffective dissemination of information, and I know we're also guilty of that at times. inadequate planning and capacity, as well as prioritization, and inadequate conduct and utilization of operational resources in health communication. So the goal of the framework is to increase awareness and create demand and utilization for primary healthcare by all stakeholders. And the objectives are as mentioned there. We have to build and strengthen political goodwill for primary healthcare and for implementation of primary healthcare at national and county level. We need to advocate for sustainable resource allocation. This was actually, I think, the main resonating complaint that's coming up is actually funding and funding. But we know that there's quite a lot we can do even with the funds that we have, and mobilization of that for the implementation of primary healthcare. We need to advocate for multi-sectoral collaboration and coordination for implementation of PHC. We also need to create awareness and increase knowledge of that, and to strengthen community ownership, engagement, and participation in primary healthcare. We know that for building a resilient primary healthcare system, we can't run away from having better governance in primary healthcare, so we play quite a big role in terms of that. How can we improve our governance of primary healthcare? How can we have increased and accountable financing in primary healthcare? And how can we ensure that you have quality in service delivery? So we need to also ensure that you have these alternative and flexible approaches. And this can only happen closest to the communities as possible. This is a place you can easily have modification in service delivery to ensure that you have continuity of services at all times. Thank you very much, and I hope that these documents will actually go to support implementation of primary healthcare. Thank you.
Thank you. Thank you very much, Dr. Agatha. A lot of work has gone into this. There's been a team working very hard, and this has come to this level, and we'd like to see that it's implemented. A lot has been said there. Advocacy, there are areas that we have weaknesses which we need to work on, and we need to commit ourselves. So at this time, I would like to welcome Dr. Maureen Kimani to also share with us an overview of community health documents which are being launched today.
Chief guest, WR, World Health Organization, Dr. Mulwa, all protocols observed. Good morning. Today, I'll be talking about some of the few documents we have developed, which are aimed at strengthening community health systems within our counties, and ultimately supporting UHC at rollout, which was recently launched. So next, please. So I'll give you a brief overview of CHS, but I know I'm talking to the converted. Everybody in this room is a PHC advocate, so I'm sure I'm talking to the converted, so I'll just be telling you how far we have gone in terms of community health services, what are our policy aspirations in the next 10 years, and some of the documents that will be supporting us to achieve those goals that we have put as a ministry in our policy. Next. So in terms of coverage of community health services, we know that the community health strategy began in this country in 2006. And since then, we have made tremendous gains with support of the leadership at the ministry, and also support of the many partners who are here today. So as a country, we have about 47 million. This is at 2019 census. I'm sure by now we have reached probably a higher number. But with about 12.2 million households, we are expected to have about 9,500 community health units. And a community health unit covers a population of about 5,000 people So it's a geographical area covering those people, and about 1,000 households in each of the community health units. So probably up to a sub-location level, you can say you have at least a unit. So we expected to have 9,500. Based on the reporting from counties that we get, we have about 8,663. That's about 91% coverage. But then we see a gap here. So counties report that we have established so many community health units. But then when you go to one of the documents I'll be showing a bit later, you find that the numbers within that in the KHIS, the Kenya Health Information System, is just about 7,900. So there are some units that are established but not given the unique number that they expected to be given and uploaded into the KHIS, so that when the CHVs collect data and their data is compiled at the sub-county level, then it can be uploaded. So we have units that are established, but they may not be reporting. But according to the data from our county community health focal persons, we have up to 8,663 community health units, and this is at June 2021. And in terms of the community health volunteers, we have moved a big step in the last 2 years from about 63% in 2020 to the current 94%. Because of the support we've gotten through UHC, where we were able to support counties to recruit and train 30,000 new community health volunteers in 2021. And then in terms of each community health unit, according to our policy, is supposed to be managed by a community health assistant, and as they progress, they are later called community health officers. And currently, we just have about 3,250. Again, this is a big boost from the UHC because we were able to employ 1,750 community health assistants, and this was spread across all the 47 counties. So again, our current coverage of 34%. So again, you can see that for the CHVs, they currently in the other 66% of the counties, they don't have anybody to supervise, to provide training, to provide mentorship, and given that their work is practical, it's skill-based. So you need someone who works with you on a day-to-day basis to continuously update you on whatever skill that you have learned and review whatever it is you're doing in the households. So we still have a gap in the implementation of community health in the country, despite the tremendous gains we have made. So this just shows what our policy journey looks like. We have the community health policy 2020 to 2030. And these are all the areas we are looking at addressing within our policy. So we are looking at leadership, management, and governance up there, ensuring that we are able to set up all the CHUs that we need for the country. As I said, we are still not at 100%. And ensuring that all the CUs are functional, and ensuring that we have clear roles. So some of the documents we are launching today will focus on the CHC roles and responsibilities. In terms of human resources for health, our main HRH in the community are the community health volunteers, who have said there are about 90,000 of them currently, and the community health assistants, about 3,200. So we need to think about their training. How do we ensure they're updated on a regular basis? Because the communities where we are like the bus. Every single health sector person wants to ride on the community. So how do we ensure that these people that we have put, the workforce of the community, are able to articulate the various preventive, promotive interventions that all the health programs in the health sector require? So we have also developed a guideline to support the CHVs in terms of their certification and training. So there's also financing. Today we shall not be launching anything around financing, but we have a community health roadmap document. I think you shall see it later, which is our advocacy tool for community health strategy. We know that in the next 5 years, we need about 44 billion to implement community health strategy, and that money is not just coming from government, it's the little money each and every partner contributes and what the community itself contributes. Because for community health, we know as much as possible, communities also pool resources to support various health interventions. Then we have service delivery. Today we shall not be launching anything around there. Health products and technologies, we have the CHV kits within our communities. Again, a big gap because a lot of our CHVs do not have those kits to be able to deliver those basic health actions they're expected to do within the communities. We have the community health information system. Again, here, the ministry, of course, is moving towards digitization of health. And therefore, we have not been left behind. We're just finishing a national pilot of the electronic community health information system. And we're looking forward to a time within the, probably in the very near future, where we shall be able to launch this and ensure that as many counties and as many partners come on board to support to ensure that when a CHV comes to a household, they don't need to carry those 513s, 514s, and so many documents, but they shall actually be just need a phone, key in whatever it is, actions they've done in the community for that day, and then the data is submitted to the National Data Center, and at the end of every month, we are able to get our reports, but beyond the reports, we can visualize on a real-time basis what is going on. So that is really the vision. So that's another big investment that is required at community health, and we shall be calling you later to think about that. So if we are able to achieve all this, then the country will move towards achieving our community health policy goal, which is to ensure that every single household is reached by quality health, and that we can actually reduce the burden of especially the communicable diseases, but support in terms of follow-up and supporting people living with chronic diseases. So today we'll be launching 5 documents from the Division of Community Health. We have the Community Health Curriculum, Community Health Committee Curriculum. The CHC is the governance structure of the Community Health Unit. We'll also be launching the CHV training and certification guidelines. We'll also be launching the community scorecard guidelines. And then the Kenya Master Community Health Unit list implementation guidelines, and an advocacy tool, which we call the Community Health Roadmap, which really shows what are the priorities we have as a ministry in terms of the community health strategy, and what are the gaps, and where can partners plug in to support the ministry. So I'll be very brief. So that's the document we'll be launching today, the Community Health Committee Curriculum. This has already been implemented for some time within the country, but we have revised and updated it because an evaluation we did in 2018 showed that a lot of the CHCs did not understand their roles and responsibilities, and we felt that it was important to probably revise the document so that we align these to the current ideals in PHC. So the curriculum covers various areas as shown there, but particularly we are looking at how do they provide better leadership and governance to the community health units, resource mobilization, social accountability, and so forth. Then today we are also for the first time launching a social accountability document called the Community Scorecard. This is a community-led governance tool, and in it we want to promote action, accountability, and responsiveness to the community needs so that the facility understands what do my consumers require, where do I need to correct, where do I need to improve. And this is not a blame game. It is not to put down the health worker in the primary healthcare facility, but it's basically to ensure that the community gets value, because we know health is a fundamental right in the Constitution, and we need to ensure that the community members who are the consumers of our services actually are able to give feedback in a more structured way to the primary healthcare caregivers. And the scorecard is expected to connect the primary healthcare facilities, the local government structures, and also the community members so that they can come and deliberate in a meeting on what they're expected to do. And for here, I want to really thank Alma. I think Alma is seated at the back, Robert, and your colleague, because Alma, who don't support community health, doc, they support malaria, but they came to us, and when they showed us what they've done in other countries, we felt that this was a tool that we needed as a ministry. And so they really supported us. We looked at what other countries have done, and we even went out and piloted this in 4 counties, and were able to see how well it can work. We called community members. They discussed about the issues they had in the health facilities. We went with the same feedback, gave it to the health facilities, and later the health facility and the community were able to come back together, and the health facility probably responded to some of the issues the community members were bringing about, but it was mainly because they may not have had adequate information. So there's a lot of information that's sitting with the healthcare workers, but it's not with the community members. So then they keep on complaining about the services that we are giving them. Then we also have, we're also launching the CHV training and certification guidelines. Again, we know that CHV serve as our first point of contact with the health system, and therefore we need to have a well-trained workforce because that's critical for service delivery. And the guidelines, they have tools within that guidelines which the community health assistants, who are the supervisors of the CHVs, can be able to use to ensure that after they are trained using the MOH community health volunteers curriculum, then within a period of 6 months to 12 months, we are able to continuously look at whatever it is they learned. Are they applying it? How are they applying it? And we can be able to certify and recertify our CHVs and ensure that our households are getting quality, preventive, promotive health services, because that's the service we want delivered at the household level. As I said earlier, we are also launching the KEMCOOL. It's the Kenya Master Community Health Unit List Implementation Guidelines. As I said before, there's a discrepancy between what the counties tell us, these are the units we have established, versus what we see on KHIS. So we felt that it was important to provide this implementation guide. And the KEMCOOL is just a subsystem of the MFL. I'm sure all of us know about the MFL code, where each and every facility is given a unique number. So for us, even all the community health units are expected to be given a unique number, and that number is also linked to their link facility. So the CU automatically knows if they have any health issue, my next point of contact or my next referral point is this facility, so that they don't just do haphazard referral mechanisms. We also know that the KEMCOOL is our foundation for an integrated community health information system. As I said earlier, we are moving towards the electronic community health information system. We are at a very advanced stage, working very closely with the digital health platform solution at the ministry led by Dr. Sitenei, and we've already gotten our data mapped already on the National Data Center, which sits at the ministry, because the vision is, as per the Data Protection Act of 2019, to have all health data, which is private data, situated at the National Data Center. So these guidelines provide a guide on creation and management of community health units in the KEMCOOL database. So basically, it's again to provide our counties and our sub-counties with guidance on how to upload a new community health unit, how to add or remove, because counties may add or remove the CUs based on how they deem fit. And of course, we are hoping that with this, it will improve access to and use of community health unit data, because more and more community health units will start reporting those who are already not reporting. We are also launching the Kenya Community Health Roadmap. And this is just a resource mobilization and advocacy tool that provides an overview of the progress we have achieved in community health in the country, our priorities, and some of the gaps we see, which probably any partner can come up and say, this is the area that would like to support. So all these documents we are launching today are geared towards ensuring that we have a strong foundation. Level 1 or community level is the foundation to the health system in Kenya. So if you have a strong foundation, I'm sure a lot of the issues we grapple with, like Dr. Salim talked about vaccination, if we had a very strong community health system, Dr. Mulwa, I don't think you'd be struggling with the vaccines program to go do social mobilization, because that will have been done by the volunteers. They will know that in this phase we are doing vaccination outreaches, and they just mobilize their households to come. You don't need to send one person to go around saying it, yeah? Because the communities are already empowered. Their CHV has talked to their household members, and everything just flows. So we are looking to that future where we are able to support all the technical divisions to achieve whatever goals they have by doing the simple things of preventing and promoting health at the household level. So thank you very much, and that's all for today.
Thank you, Dr. Maureen, and I think you've all understood the documents that we are launching, what is in there. And we'd like to hear now from the counties. There's some experiences. We've been able, you can see in the program, we have 4 counties. We've been able to get 2 counties present here. We were looking for Makueni and Kilifi, but we have not got the representatives. But I'll call Dr. Kennedy Ombogo from Migori. Just two key things maybe, or 3 you've experienced in your county, so that we can learn from it. Karibu.
The chief guest, Dr. Kibias, the Director of Medical Services, Dr. Mulwa, the partners present. I'm too tall for this. I'll carry it. Directors of health, CHMT members present. So thank you so much, and I'll say that I'm pleased to be part of history in.
Thank you, Daktari. I'd like to be tall like you. Yeah. So we've heard from Migori. It means these documents being launched are actually working. They have not just been done at the desk of Dr. Maureen. They went down to the county and they were able to get information.
The national guideline for primary health care implementation, and that time we have also increased and strengthened the linkage and referral systematic upward and downward referrals at different facilities. Of course, in the concept, we were reducing the haphazard approach of, management of health service delivery by reducing just in-work patients to following the referral systems. In that regard, we have strengthened the network so that there's a linkage between the communities and also the service delivered at different levels. Also, we have focused on adoption of multidisciplinary team. That one is a key strategy in the primary health care implementation. Of course, all facilities has a human workforce of different cadres. So the current human workforce we have is we reorganize it to to be a multidisciplinary approach so that we provide a holistic approach of client and patient care. Finally, we are now at the process of monitoring of all our implementations so that we see the achievement and where we are on the concepts we have already implemented. But in our experience, we have identified that when we have implemented this one, there is increased demand for service delivery, and that one call for increased supplies from human resource to commodities availabilities and also infrastructure. Therefore, it needs more financial inputs. So it needs to be reinvested in finance for implementation of these new concepts. As a Garissa County, we introduced a bill of facility improvement funds at the county level. Already it is at the Assembly Participation Committee, public participation, and also community health strategy bill, so that we reinvest some financial resource as the demand is created since the community have been mobilized, and now awareness has been increased so that health service seeking is increased. I think that's how much we are now, and currently we are rolling out all these concepts to the 7 sub-counties in Garissa County. Thank you.
Thank you. Thank you, Dr. Mohammed. We've also heard now what happened in Garissa and what is happening, so work is moving. So we're expecting Makueni to be represented. Dr. Mula, it looks like you came over and came the online. Okay. I don't know whether it's possible for them to give a, can they? Okay, somebody online from Makueni? Can you speak? Makueni, online? Okay, I think we will not be able to get them. We'll move on with the program, and at this time, I'd like to, before I invite Dr. Salim, Dr. Salim has 3 ladies who he always feels like they push him too much. So the Division of Health Promotion should be also launching something, but it's coming. We are working on a policy. We are going to review our strategy, which was launched some time back, and some guidelines, and so we'll be calling you back. So Dr. Salim will take us to the next level. The ladies have done it. Can we clap for them? And behind those ladies are gentlemen. So the gentleman you've heard.
Vice Chair, Karibu, Mr. Thomas.
You'll probably allow me to remove this. Thanks, Doc. And yeah, I think, ladies and gentlemen, I think it's very exciting to be here this morning. But before I start, to really our chief guest, Dr. Kibias, also the Director of Medical Services, Preventive and Promotive, Dr. Andumulwa, teams from ministry, both at national level, including the primary healthcare team, and all the other stakeholders who are there, the counties, partners, invited guests, media, ladies and gentlemen, all protocols observed. I think mine is going to be very, very short, very few remarks on behalf of HENET. So as indicated, my name is Thomas Onyango. I'm the Country Director of Living Goods, but I really speak on behalf of the Health NGOs Network for Kenya. I think our first statement really today is really a moment of gratitude. And first of all, we really want to thank ministry for what I call great leadership and stewardship towards this. I think it's rather clear that the documents are not just, they're not pieces of paper. They've been thought through, and they're very necessary. And actually bring it a bit home, I thought I'd probably leave the speech alone and just listen to what was going on and really articulate what's really happening on the ground. As an implementing partner, and many partners here have experienced the same things, that there's a lot of great steps happening, but there have been a lot of gaps, okay, which need to be streamlined. Part of them in very simple things, like just policies, clear training guidelines, which the drive standardization, so that ultimately there is what I call service delivery at the end of it. I think we're really proud of the work being done and really appreciate the collaborative effort by ministry and other stakeholders to make this thing work. The next thing I want to talk about is really that, and I had a bit of it, Dr. Lago speak a bit, and Dr. Maureen give a bit of a tinge of it, why I think it's really pretty important for all of us here. That there's a concept people talk about, a double disease burden. We know in most of the developing world, we still have communicable diseases, very high, okay? So, and then we have the NCDs, but I think the bigger worrying trend, which many people never speak about, is the incidence. So the rise in NCDs is faster than in the developed world. So if you look at it, we already have a strained system, as it were, but then you have a lot of big problems to solve, okay? So problems at scale. So given that, I think it needs all of us to be, to think a bit more transformatively, in how to drive solutions that will not just solve the problem, but also be sustainable. And I think I'm very glad, all of us are very glad, as a network, as partners, and all of us here, that that's what the government is trying to do. That, if you look at the policies in the sort of, each and one of them, I think the sort of ideas being put through are things that will not solve the problems just today, but will ensure that we can drive that sustainability in the long term. Coming very directly to community health, which is we're all passionate about, I think we all know that there's been an investment case by ministry, I think 2-3 years back, that for every dollar spent, you get a 9.4 times return on it, okay? Almost 10x, okay? And I think also wanted to bring it home with the fact what Dr. Maureen was talking about, the role of preventive promotive, okay? So if you have the population is burgeoning, okay, of course, money is becoming less, we're having a lot of disease burden, so we need to have that big solution mindset, which we are seeing with all of us happening. I think these days the world doesn't go, you don't finish any place without talking about COVID, okay? But I think COVID has taught us a lot of things we should be proud of in some way as well, okay? But even for global, if you look at it from a global perspective, for places where people had not invested sufficiently in health, there's been an aha moment that we need to invest in health, okay? And bring it back to community health, and what Dr. Maureen was talking about at some point, that has been the first point of contact in terms of sensitization. Assuming all these things are also working effectively, even things like vaccination, maybe there's been last mile delivery to using the community health workers. Now, I want to talk a bit about the future, because I know we've talked about the documents and the policies and what they have been launched, and I think all of us are proud so far with the work done up to where we are. I think the more important thing for us now is to think of how do we take these things forward. And I heard about either Gladys or somebody was talking about the role of stakeholders. And the stakeholders in this case is not just government, it's all of us. So I think maybe as we close, I think we have some homework to do to really think of how do we work collaboratively more together. I know we are doing a lot of great work, but to achieve this transformative agenda, leveraging on these policies and bring them to life. And for some of us working at sub-national levels, I also wanted to bring a bit of what I call organization policy. That to have effective service delivery at the community level, it's not, many people think about, and like we saw about the training curriculum, okay? Which is one piece of it. There is going to be something, training is just one piece, and I call that under-equipping. So you build skills and capabilities, as an example, okay? But in our organization, Dr. Salim talked about a desk, which was the table, but we also have an acronym called a desk, which I wanted to leave all of us with. A simple thing, that to have effective service delivery at the community level, you need to have we call it DEAC, which is really that you have to leverage on digital, okay, to ensure that community health workers or the system is equipped, supervised, and compensated. And equipped goes back to all the policies here. How are they trained? How are they kitted? And all those things, okay? We go about the supervision, which is a critical pillar. And Dr. Maureen was talking about it because these are the people who handhold CHWs every day. We've realized there's a huge gap there, where we're actually at 34% of national requirement. So how do we leapfrog that even further? And how do we leverage on things like digital mechanisms to also overcome part of those headcount gaps that are there, to have effective service delivery, okay? And then lastly, also that they're compensated. But all these things also can also not be done if you not draw them back to the point of my friend Angela's passion about health financing. It all comes down to the money. There's budgets, and we're all talking about them, okay? And also policies to ring-fence that money. So looking at the future, I think what I want to leave the audience here with is really that as partners, one, we are very proud, but I also want to give you a total commitment moving forward that we'll work at different levels just to ensure that we can all bring in our resourcing. And resourcing not just about money. It just brings, whether it's skills, technical, whatever it is, to ensure that holistically is aligned within the government framework to achieve the UHC dream. Otherwise, very happy and really very proud of this. And I just want to thank the team once again for the great job done. Thank you.
Thank you very much, Thomas. And especially, I picked the last sentence, which I'll not forget, commitment to bring resources. I will pretend I did not hear, it did not just means funds. Okay. So I'll take this opportunity now to welcome Mr. Anthony, who is actually one of our great friends, working with several organizations under the banner of community health units for UHC, which is very important, especially after we have launched our UHC last week. So Anthony is the Director of Global Community Impact for Sub-Saharan African and Johnson & Johnson Foundation, with a mandate to deliver the Global Community Impact Strategy, which is focused on supporting and championing frontline health workers. Anthony has vast knowledge of the pharmaceutical sector in East Africa, having worked in the pharmaceutical market in Kenya and East Africa for 16 years. Johnson & Johnson have been supporting the Department of Primary Health Care through the Community Health Unit for UHC group of partners and gives the best example of public-private partnership at work. These are almost 4 partners are there. I just want also to mention that Anthony, before he moved further away from where he was a great champion of supporting capacity building of the community health extension workers. I think it was still in Novartis. So I'm very grateful, yes, which really supported most of our counties. We picked several community health extension workers. We took them to KMTC, to the first group that were actually trained there under our revised curriculum, which KMTC now actually adopted. Karibu, Mr. Anthony.
Thank you very much, Dr. Salim. And I think it's quite interesting that you've just mentioned I'm a drug dealer for 16 years in public, so asante. But I think my reason for standing here, and I stand here on behalf of Johnson & Johnson Foundation, but I also really stand here on behalf and to speak about the Community Health Units for UHC platform. This is a platform that brings together stakeholders led by government. And I believe you've heard about Dr. Maureen Kimani. I'm sure you've seen how well she smiles and she's happy with you. She's very tough. And she manages us very, very well. And Mr. Wanyungu, who is our co-chair of the platform and was appointed to work with us, has really shown us government-led ownership and guidance for what we want to deliver for community health services. Guest of honor, Dr. Kibias, on behalf of Dr. Amoth, Dr. Mulwa, who we have been seeking to meet for quite some time now. You've been very busy, Daktari, since you got into your office. Dr. Juliet Nabionga, who was actually on the first conversation when we started thinking about what should this platform look like and what should a collaborative approach by stakeholders to engage with government for community health services. And I think this is almost, how do you call it, an amazing lining up of stars to have you in the room when this is happening. So looking forward to what we can do in future. And for me, I think the reason why this is so important, and this is actually articulated in the Community Health Roadmap for Kenya, and I'll try and read so I don't mess this up. It's one of the key urgent investment actions is to create a platform for strategic partnership and accountability among stakeholders at all levels within the community health service. As Thomas very articulately stated, we have a big challenge. We all here, and everyone out of here, always say community health services is a foundation. Everyone states that you need community health services to deliver primary health care. Community health units are a key part of primary health care networks. However, we don't follow it with the resources to ensure that we deliver a platform. Our agenda is really that. How do we ensure that, first of all, whatever little resource we have right now is used in the most efficient way, where stakeholders and partners are transparent, they say exactly what they're doing, they state their areas of strength, and therefore we can work together to ensure that we are most efficient in using whatever resources available. We have the strategy, we have these documents that anchor whatever we do in policy, so that we ensure that whatever we're doing in the long term will be sustainable. So my call out today is that we continue in this approach. We continue to support the ministry in this one way, and this platform is an open platform for all stakeholders to come together. Let's work together and ensure that we can use these resources that we have in the best way. And just to highlight that Dr. Salim's question here on resources, I think, Daktari, when you talked about when we were supporting the CHEW strategy, I think that was around 2016. We could hardly get enough partners to fill a table. We used to meet just in the community health boardroom, and we could hardly fill it. Right now, we are almost filling the room with partners. So my belief is that when you have such strong government leadership, and you have commitment from partners to work on one plan, it even attracts more resources. And a good example of this is that as we started this platform in 2019, it was only J&J that was supporting the core of this platform. But 1 year later, with the success that we've been able to see, this initial commitment of $3.2 million has actually grown to $8.4 million because we got Elmer Philanthropies that accepted to come in, and they also were very clear. We want to come in to support the collaboration. We want to come in to support the one plan that all partners are working towards. So I want to encourage that we continue in that direction. And I see a lot of light this year in terms of the opportunities for funding for us to really prove that community health services can deliver for delivery of UHC. And I want just to mention the partners that we have in the platform so that I don't forget to represent my members. So I think we started with AMREF as we were thinking through this. We have UNICEF, who are really the thought leader on this and representing the UN agencies. Living Goods, represented by Thomas here, Financing Alliance for Health, and a special call out to Angela, who just doesn't talk finance, but she actually helps us look for finance. So the Elmer Philanthropy opportunity, she actually could have chosen to go and sit with them and talk as one agency and get her resources. But she said, I think it will be more catalytic if it comes into the platform. So well done, Angela, for that. We have Julius from Luala, who is our co-chair. We have KENYA-AFYA that is focusing on Kajiado. Spark Health Africa that is helping us with the leadership and management part of this and building a proper organization of the platform, and Medic Mobile, who've been working with Living Goods on the ECHIS part. So as I close, I just really want to say that we've come from far. We are riding now on a wave where no one can ask what the value of community health services is. But now we must convert that into action. I think we are doing very well in setting the policy framework. We now need to show what this is delivering at a community health unit level. How do we convert all this great momentum into functional community health units that deliver for UHC in Kenya? And that, for me, is my call out, that we really do that. And for that, we really need the county health management teams that are here. We are honored that you're here with us to launch this, because at the end of the day, community health services are delivered at county, and we seek to work with you to ensure that we deliver this dream. Thank you very much.
Thank you very much, Anthony Gitau. The only thing I think I picked and I didn't want to forget is we need to transform these documents into implementation, and we're very grateful that the county directors of health are here. And most after devolution, we have realized the complementary synergy that we need to have together. I remember in 2014, when I was very new still in community health, I went to a county and I was chased. I was told we do not need community health. Yeah. So I'll take this opportunity now to welcome a great partner when community health is still stuck there. He works very hard and silently. This is Dr. Meshak Ndirangu, who is representing AMREF Kenya. So Dr. Ndirangu has more experience, worked in this space for more than 20 years, providing leadership for public health initiatives in Africa. I'm very glad that he has held our hand most of the time and up to this stage, and we believe we are going to continue working together. Karibu, Daktari.
Thank you very much, Dr. Salim, for very kind words. It's always a pleasure working with you and your team, Maureen, Wanyungu, Gladys, and all of you. I think we have come a long way, and as we have been challenged by yourself, by Johnson & Johnson, Anthony, and also by Hennet, we have a long way to go. This is not the end, but really the beginning of the next leap that we need to make as a country. So, Dr. Simon Kibias and my very good friend on studying for the Director General of Medical Services, Dr. Mulwa, it's always a pleasure to see you. I can't stop telling you congrats for coming to AFYA House. Dr. Salim Hussein, Dr. Juliet Nabionga, World Health Organization, Anthony Gitau, immense supporter on this journey, all the heads of different organizations, Path, Living Goods, Laura Community Alliance, Financing Alliance for Health, Angela, I can see you there, Alma, and others, all partners represented, and including directors of various organizations. I can see Dr. Lilian Otiso from LVCT, and also the country director of PATH, distinguished guests and all protocols observed. It gives AMREF Health Africa immense joy to join you here today to witness the official launch of the Ministry of Health Primary Health Care document. As a country, we are celebrating a big milestone, a huge milestone. The Ministry of Health has worked with stakeholders to strengthen primary health care as a pathway towards attainment of universal health coverage. We are celebrating this milestone by launching 5 core documents, guidelines and curricula to guide the rollout, advocacy, communication, training, and measurement of the progress we make in primary health care at community level and as a linkage to the formal health system. And so, on behalf of AMREF Health Africa, I truly congratulate the Ministry of Health, Dr. Kibias, Dr. Mulwa, Salim, and all, Dr. Maureen, and all of you, and also Council of Governors, and all stakeholders for this meaningful achievement. It's not just a big achievement, but it's meaningful for our country. Ladies and gentlemen, as AMREF Africa, we remain immensely proud of being an active member of the partnership that is delivering these gains for the people of Kenya. And we appreciate the leadership role that the primary health care department has played, coordinating with all partners to get us to where we are today. So I can only echo what Anthony has said. Salim, Gladys, Maureen, I still remember the battle on the COVID-19, really the type of collaboration that went into that. Please continue providing that leadership. Sometimes it's all we need to keep moving forward. We thank and deeply appreciate the support that government partners have provided towards the achievement that we are celebrating today. And I would like to specifically commend Johnson & Johnson, thank you very much, Anthony, Elma Foundation, and also the Global Fund, who have played a very deliberate and intentional financing and guiding role along this journey, working with the WHO and other development agencies. I would also like, and I cannot overdo it because Anthony has said it, to further appreciate the CHU for UHC partners, UNICEF, Lola Community Alliance, Financing Alliance, Living Goods, and KENYA-AFYA, again for their contribution to this journey. As we look into the future, I can only tell you that AMREF Africa remains deeply committed to supporting implementation after the launch today. I think Anthony has challenged us that these are documents, but really what matters is what we do with them after now. As you know, community health work has been and remains at the heart of our organization. And we commend all of you for joining this belief over the years. We believe in people-centered health systems. And in line with this belief, we pledge Maureen, Salim, Dr. Kibias, we pledge to continue supporting this journey. And specifically, in addition to what we have done, we'll support the certification of all CHVs in Kenya, supporting the Ministry of Health on that. The rollout of CHC training in at least 12 counties, because we now have the materials, and continue supporting the formation of primary care networks in multiple counties. I listened to Dr. Agatha. I don't think we have met a lot, but I'll never forget how I felt when all of a sudden we could see it's like we are imagining PHC and really asking, how do we make PHC work for people? Additionally, with the trained CHCs, we'll support the rollout of community scorecards in multiple counties. And this philosophy of social accountability in the health sector and really embracing people as agents of social accountability is very important in moving our country forward. Before I end, allow me to say that as we engage towards implementing what we are launching today, let us work closely and in partnership with county governments. And we're happy that we have listened to two representatives, Garissa and the other one who has spoken, the tall one. I can see you. Migori, from Migori. Let us remember to work very closely with county governments and council of governors in order to make the gains in primary health care that we are. As AMREF Africa, we would like to call upon county governments to do 4 things. Number 1, we would like to call on county governments across the country to adopt these 5 documents and develop implementation frameworks for each of them. Number 2, we'd also like to call upon the 47 county governments to increase sustainable and equitable domestic financing from primary health care, including community health. And we truly commend the counties that are already moving resources into community health. We have seen that happen across the country, and they know themselves. We can only commend you. Number 3, and I can only echo what Hennet has said, promote the use of technology, especially the mobile phone for community health data, including social insurance, training for community health volunteers, and to obtain health information. Let us use technology to bed the cost curve of delivering community health care. I believe by embracing technology, we can lower the cost by a factor of probably 5 or 10. What may have cost 1 million shillings could end up costing probably 200,000 or less. And yet, on the same quality, as we have demonstrated over and over again, that digital training and all that, when supported through local mentorship in the spirit of primary care networks, has the same efficacy, but much more cost-effective. Finally, we call upon the 47 county governments to institutionalize community health for retention and motivation of the workforce by enacting specific county laws. Immense congratulations to 14 counties that have already made county laws, that have enacted bills and made them into laws through their county assemblies, recognizing community health workforce, and therefore providing a stable framework for current and future county governments to invest in community health. Without a framework, a county government, you come in and never remember our community health workers. But with a framework, we are creating stability even as we move from one county government to another and truly consolidating the gains of devolution. So, once again, on behalf of our organization, I congratulate each of you for the work that you've put in to deliver these important documents. It's only the beginning. Let's walk the journey. And once again, you can count on the support of AMREF. Thank you, and may God bless you. Thank you.
So I think it cannot be overemphasized. County commitment, counties' partnership and synergy is very important to take us now to the next stage of implementation of this document. We'll take this opportunity now to invite our great friend, and sometimes these names are actually made in heaven. So Path has given us the path to continue this primary health care. There's been a lot of support, especially for me. What I remember for Path for is the advocacy to the parliamentarians. So most of the parliamentarians currently, and especially the health committee there, they can actually currently speak about primary health care with confidence. We have had several meetings with them. Initially, they did not really understand, but currently, I'm actually glad when they are there, they can actually speak about it. Hopefully, that the bills that are going to support community health that are either in the Assembly or the Senate, they'll pass through because of some of the effort that PATH has done. Caroline Njuguna is PATH East African and Regional Director, and doubles also as PATH Kenya Country Director. She is responsible for providing strategic leadership and guidance across PATH's activities and operations in East Africa while overseeing PATH programs in Kenya. Caroline is an experienced program leader under digital technology. She loves digital area. I think this is also very important for us. This will be a game changer for all of us for providing our services. She has extensive experience in digital transformation as well as in international development. Prior to joining PATH, Caroline has held various leadership positions both in the private sector and the development sector, namely Access Kenya, Safaricom, Goal, Island, and Christian Aid. Karibu, Caroline.
Thank you, Dr. Salim, for that very generous and kind introduction. And I wish to confirm, indeed, PATH is a pathway to so many things. So you're in the right forum, and I'm really pleased to be here today. Distinguished guests, ladies and gentlemen, all protocols observed, good morning. Good morning once again. I must say, as PATH, we are extremely delighted and honored to be part and parcel of this important launch of the primary healthcare policy documents, including those for community health services. PATH, just like many other partners who've spoken before me, wishes to congratulate the Ministry of Health on the finalization of these key documents that seek to strengthen primary health framework in Kenya. And I must say the timing is great. And I say that for a couple of reasons. I think just a few days ago, the President launched UHC, and I believe that this is a clear indication that the country is committed to improving access to essential healthcare for all its citizens. It's also quite encouraging and remarkable to see a wide range of representation of partners in the room today, and I also believe virtually, again, a clear indicator of the collaborative approach that our country has taken and adopted in pursuit for health for all. I think many of the speakers who've spoken before me have emphasized on the need for multi-sectorial approach, and Dr. Agatha put it very well, and I believe I don't need to say any more regarding that. So for those of you who may not be familiar with PATH and our mandate, just allow me to just bring you up to speed who we are and what we do. So PATH, we are a global team of innovators working around the globe to eliminate inequities so that people, communities, and economies can thrive. At our core, we believe that better health moves humanity forward. When people are healthy, they get to go to school, they get to go to work, they engage in meaningful economic activities, and ultimately, they can focus on their future and build more and prosperous lives. Our work is clustered across 5 platforms. One is vaccines, drugs, devices, diagnostics, and last but not least, system and service innovations. So over the years, we've implemented sustainable health solutions that align with our country needs, but also with our country priorities. So here in Kenya, our work is truly anchored on primary health care and recognizes that PHC is the expressway to achieving UHC. And I believe this has been highlighted by a couple of speakers who came before me. At the core of our internal PATH PHC strategy of 2021 to 2025 is the understanding that evidence-based interventions that are implemented through a people-centered approach and equitable approach and owned by the people for whom they are ostensibly meant is the only way to achieve our goals. As PATH, we have a long history of supporting people-centered delivery of essential health services. So we continue to remain committed to collaborating with the ministry and other partners to strengthen PHC systems to ensure equity in access to healthcare. And in all these, a lot has been said about sustainability. And I believe in all these PHC initiatives and interventions, sustainability is of essence. And one way of injecting it is through a facilitative policy environment and adequate financial investment. PATH advocacy team, and Dr. Salim has mentioned it, has continued to work with the Ministry of Health and other partners at both the national and sub-national level, engaging the counties to support policy change across a couple of areas. Allow me to just highlight there are 7 areas where we've been working with all these partners from a policy perspective. The first one is to address the several leading killer of women, newborn, and children. The second area is advocating for increased investment in the area of reproductive, maternal, newborn, and child health. The other area is in the space of immunization, as well as global health, research, and development. We've also worked with partners in the ministry around supporting sub-national advocacy and citizen engagement for women and children's health. Elevating political support for global health and R&D, aligning regulatory systems at national and regional levels to support R&D and maternal, newborn, and child health products like chlorhexidine and access to health technologies. Last but not least, somebody said in this age you can't talk about PHC and not mention COVID. We've provided technical support to the introduction and rollout of COVID-19 vaccines. And to the theme of the day, I believe we saw the theme in the banner, Afya Yetu, Jukumu Letu. Perth has continued to support the Department of PHC under Dr. Salim Hussein leadership, working with his team to finalize the primary care network guidelines and the PHC advocacy, communication, and community engagement framework, which we are launching this morning. Now, to enhance implementation, Perth has supported orientation of counties to the PCN guidelines and exposed them to peer learning from front-runner counties that have already been mentioned here before, like Garissa. We've also heard from Migori. So, ladies and gentlemen, as we launch these policy documents today and successful implementation of these policies, now following the President's launch of UHC on Monday, allow me to reiterate that health financing is a key parameter of health system performance. Since PHC is the vehicle that we are using to achieve UHC, I call upon all of us in the room today, those of us who are there virtually, to join hands and seek innovative approaches. I think somebody has said it's not business as usual. The resources will always be limited, but we have to think differently, strategically, and in an innovative way. How do we finance PHC? To my fellow partners, and allow me to take a pause here. I know it's been said before, but I want to make a clarion call. The private sector, partners, let's continue leveraging on the resources available to complement the government efforts in implementing PHC and strengthening it. It takes all of us to join our hands for this to be achieved. Like I've said from the theme today, Afya Yetu, Jukumu Letu. It's a shared responsibility. If we hold hands, we achieve more. If we work together, we go far. So I wish to acknowledge and relay our appreciation to all stakeholders that have been involved in this piece of work, ranging from our development partners, and allow me to call out the Bill and Melinda Gates Foundation, among others, the Ministry of Health, both at the national level and also counties, and specifically the Lake Region Economic Bloc. As an institution, Perth commits. We are committing to continue partnering levels to accelerate the implementation of this policy, and we'll do this by facilitating dissemination. I know Dr. Salim wanted us to get a bit granular on how we are going to support this. So in response to that, we'll facilitate the dissemination. We are going to continue supporting the cross-county learning and documenting the working strategies for scale-up. So with those few remarks, I wish to thank you all for your attention, and once again, really thrilled to be part of this journey. Thank you.
Very much, Caroline. I think she has correctly said it. The only path is for us to unite in this space of community health. Before I continue with the rest of the speakers, I want to say that PHC for us is also Person's Happiness Center, na leo tunasherehekea na mmenyamaza sana, so nataka kila mtu aseme PHC oye, PHC oye, PHC oye. So with the permission from the acting WR, Dr. Julia, somebody who will be a bit of history why I'm calling
that up. But we've also done quite a lot on community health, and it's a passion. It's a passion for me. It was a passion even for our former directors, and we've always taken it on. And so we're really proud that we've made all these steps and milestones. And yes, as the big five and just justifying, and we're excited to see at least community health get into UHC, and that was really a proud moment for us. So as LVCT, we continue to support different counties, and I'm really glad to see some of the counties we work with. We have Homa Bay, I think I've seen Taita, and the others that we've been working with in terms of our HIV and other programs. But within that, our model and our goal has always been, how do we bring sustainability and how do we align it with the other national priorities? So for example, the community health work, and really trying to ensure that there's that integration. And for me, the challenge for us is really ensuring that integration happens. As donor funding declines, how do we ensure that whatever we do is anchored? For example, our HIV programs now being anchored in the primary healthcare networks. It's a gap. We know it's a vertical program, but I'd like to urge especially government to facilitate these conversations so it's easier for us to implement. We're very happy to be supporting COVID vaccination support across the counties we support. And again, just learning and hearing from the counties that have been able to use the community health and PHC to get this working, I think is a model we should all aim to sustain. And finally, just to really echo what Dr. Salim has said, we are passionate about quality. We've supported quality improvement initiatives, taking it from a very complex, jargon-full concept to come up with a root cause analysis of what is affecting the delivery of services. And we are excited now that this has been taken up by the government and is being scaled up across different counties, and we're supporting that. So we are committed to being involved in this, and actually also committed to joining the CHU for UHC platform as a way to ensure that we can take this agenda forward and to see UHC being attained with the community health and primary healthcare networks. And congratulations to the ladies in the department. I'm happy to have been working with you this journey and to guarantee my support that as LVCT we will continue to do this and do it for the country and do it for the people we work with. So thank you, and also just to recognize my colleagues who've been very significant in doing all this work. So we will continue to do research and program and implementation to contribute to the evidence that ensures that the documents and
20 years within Africa, focusing mainly on building a country's capacity, designing, implementing, and evaluating health sector reforms and health system performance assessment. She has extensive research experience on various aspects of health system and health services, such as knowledge translation, health financing, evaluation of health sector reforms, service delivery, health and poverty and economic evaluation of health programs and intervention. Dr. Juliet is a graduate of Bachelor of Medicine and Surgery of Makerere University. She has also a Master of Science in Health Economics, University of York, and has a PhD in Public Health. So we are in very safe hands. Karibu, Dr.
Oh, Dr. Slim, that was really long. I didn't give it to him. I think he Googled it himself. I prefer making it shorter. Good morning, ladies and gentlemen. Yes, I acknowledge here the senior leadership of the Minister of Health, Dr. Kibias, who is the guest of honor, Dr. Mora, senior staff from Minister of Health, the national level and the county partners here. So I think I want to start by saying that we, as the World Health Organization, we are really pleased to be part of this event, launching these documents that will guide the implementation of primary health care. And this is very important to ensure a common understanding of what we all need to do. And I want to take us back to where we've come from. PHC is not new. And if you recall, the evaluation of the earlier efforts raised some very important findings. Among the things that failed PHC was the varied understanding, varied implementation approaches, and actually even gave rise to some fragmentations, the birth of global health initiatives, focused program implementation. So we lacked that comprehensive and harmonized approach to implement PHC, and maybe that partially explains the results that we saw, that not many countries made significant progress in this endeavor. So, ladies and gentlemen, PHC is the most inclusive, effective, and efficient approach to enhance people's physical and mental health, as well as social well-being. And it's a cornerstone of achieving universal health coverage, sustainable development goals, and building health security. Many speakers have made reference to the timeliness of the launch we are witnessing today, that it comes soon after His Excellency, the President of Kenya, Uhuru Kenyatta, launched the national scale-up of UHC in Mombasa. And really, this gives us the political commitment to implement what we think works for the people of Kenya and move towards UHC. We also learned from the COVID pandemic. And here I want to emphasize the role of communities, which is not new. And as the World Health Organization, we have a very strong component of this in responding to epidemics and disease outbreaks and emergencies. The role of communities, which is actually one of the components of PHC, that empower the people and communities. And this is also important for building community resilience. While the Minister of Health is launching these important documents, it's important to note that PHC is not just starting now. There are some lessons we want to pick from past experiences and take care of this and watch out for this as we move forward. Again, strong reference to moving forward, as earlier speakers have mentioned, and I want to highlight just a few. I want to make reference to the Lancet Commission for Financing Primary Health Care, and it made significant statements, you know, why PHC is failing in its promise in many countries. Previous speakers have made reference to the financing, that actually we make commitments that are not financed. And I think this is, I don't know why we don't learn from this, because we do it all, every time we do it. We develop sector strategies that are not financed. We design reforms that are not financed. We design PHC frameworks that are not financed. And I love it when I sit in meetings and people say, oh, we need innovation. But I really support innovation. My friend from Perth, I do support innovation. But there are also some basics that are really fundamental, and we need to implement them. When we fail to implement them, we look for innovation. Something as basic as washing hands doesn't need innovation, but we don't do it. So I think the financial commitment, the political commitment is very important to realizing PHC. And again, it's not only the money, but how we allocate. We need to align it to priorities. The flow of resources, it must get to the frontline workers. Accountability, we need to account for the money. We need to improve efficiency. And improving efficiency, because I lead the financing program of the WHO African region, when we talk of efficiency, people think that it's only us who are in health economics who should look out for, ensure efficiency. But efficiency is everybody's responsibility, you know. Even something as important as adherence to treatment protocols improves efficiency. Ensuring use of health facilities improves efficiency. So I think, when we talk of resources, again, I think that was a colleague from AMREF who talked about resources comprehensively. We need to put our hand where our mouth is. I hope I say that right. And also really make sure that we look at those resources comprehensively, and really all of us commit to PHC. We need to protect users from financial hardships. And again, we are lucky that the President himself is committed to the scale-up of the National Health Insurance Scheme, the enrollment of indigents. You know, this is what PHC is all about, protecting communities. And this lesson should inform our outlook as we plan to re-energize in strengthening primary health care. So, what do we need to look out for? In Kenya, while devolution leads to immense gains with regards to responsiveness of the system, it has also brought some challenges that we need to be cautious about as we map our way forward to revitalizing PHC. And I want to emphasize a few. The one issue is the governance. Again, one of the earlier speakers made reference to the issue of social accountability. You know, we put a lot of effort on monitoring financial accountability, reporting results to the national level. And more important, we need to be accountable to the people we serve. And we need to allow them that window to even really take us to task to explain whether we are meeting our commitments. Financing of facilities, again, the President himself made reference to this in his speech on Monday, where he emphasized the issue of granting more financial autonomy to health facilities. I think I've been lucky to be working with Kenya many years, even before I came here as acting WHO representative. And I was here for the evaluation of the sector strategy in was it February? And we went to all the counties and we interfaced with even health facilities. And I was amazed to see that actually they would say that we don't even know how much money we are going to receive. I hope, Dr. Mura, I'm not, I mean, I think it's better we face facts if we are going to address challenges. They don't know how much money they are going to receive. The budgets are predetermined from the county level. So what room do you have to allocate in line with the priorities? And that's also an efficiency issue. So again, the President made reference to the autonomy in financing of health facilities. Management of human resources. I was happy to hear the comment on multidisciplinary teams. This is important. Dr. Mura, I remember your comment when we were in the Human Resource Conference earlier this week. And you said that our training trains us to be siloed. I'm a pharmacist, I push for what is it that is in the pharmacy department. I'm a nutritionist, but you're addressing a person who is one whole. So really, we need to change that thinking and embrace this idea that we're a team looking after the well-being of a given individual. So what are our expectations this morning? That actual work starts after the launch. With a devolved health system, the guideline documents will be important in ensuring a harmonized approach to implementation of PHC. And these documents should be able to guide counties as they explore ways of making healthcare more people-centered, accessible, and responsive. And it will be important for counties and the national documents implementation and to support cross-learning across counties. And I think Path also said that this is one of their areas. It's important that we continue learning from each other. So ladies and gentlemen, I want to emphasize that real action will be done out of this room. While documents are useful in elaborating the action that we need to undertake for PHC to become a reality, the two levels will have to work together in ensuring that these documents are disseminated and operationalized within the counties. And I want to emphasize that the point of effective dissemination of these documents beyond merely sharing these in meetings is very, very important. Regarding the linkage between the county and the national, Professor Anyang Nyongo made a comment on this, that it was a missing link in the devolution discourse. You know, counties, you think, of course, this is a devolved system, they have the power, but you also need the national center. And that linkage is important for the whole system to move together. And I also want to make a comment on the issue of effective dissemination. I've been working many years in Africa, evaluating health sector performance. Oftentimes, we go to evaluate sector strategies, and actually even senior level Minister of Health people have never read them. And as the Director General who was chairing the meeting kept swinging the sector strategy, the team is here to help us evaluate this. The commissioner asks me, who just came, what document is that? So really, we are evaluating something people do not, and I've seen, no, I think it's, I don't know why it's a common happening, and I've been at it 20 years. You ask somebody, what is in it for your program? No, actually, I'm not aware, but we developed ours. We don't know, maybe the people who were there didn't even know what they were doing. And you've been implementing it for 5 years. So I think, friends, this shouldn't happen to the beautiful documents we have today, where a lot of consultation has gone in, resources, and really they lay out a good roadmap for us. And innovation, I mean, dissemination, we need to be innovative. These are big documents. Our reading culture is not up to it. So what is the best way to make people know what's in there? It will take more than one encounter. It will take multiple products, maybe a leaflet, maybe meetings, maybe radio. But I think let's all think creatively. How do we send the message around to galvanize all efforts in a common direction? So as the World Health Organization, we are committed to support the national level, to support counties, to work with the partners, to ensure that we really translate these documents into what we want to see, to push the PHC agenda, to push the UHC agenda, to build health security, and even more important, to build resilience at community level. So, ladies and gentlemen, I want to thank you so much.
Thank you very much, WR. We are very glad that you're actually looking ahead in terms of dissemination, so that it is not a distribution of documents, but a real dissemination, and we should look at doing it in a manner that is effective. We are very glad also for your commitment that you are going to support us in the same. The issue of empowerment of our individuals and our community, very important for us in primary health care. Where it is a person's happiness center, we really want to take the responsibility back to the community. Accountability, I think we are trying. That is what one of our documents that is going to answer that issue of accountability and give voices to the community. Rest assured that our documents, even as I had alluded to earlier, before we developed and launched them, they were actually being tested in several counties. So we just now request that we have a partnership so that we can roll out this to all the other counties. Any representative from COG who are still waiting? So if not, I would like to fill that gap by welcoming Dr. Gordon Okomo, who is actually the chair of all the county head directors of health. Dr. Okomo is a medical doctor with a passion in public health system strengthening. He's an epidemiologist and has a passion in disease control. He is a PhD student who has several papers in maternal and child health. He has over 16 years of experience in healthcare management, and where he comes from, Homa Bay is one of the counties that we really been working and trying to get some of the evidence in terms of community health volunteers, which way can they work, which drugs they cannot use, and I'm glad that one of the research there gave some policy direction. Dr. Okomo, karibu.
So the guest of honor today, Dr. Kibias, OGW, the Acting Director, Medical Services and Preventive and Promotive Services, Dr. Andrew Muller, who is also a colleague and a friend, our development partners represented here, ladies and gentlemen, both physically here and online. Good morning. Good morning again. It's a pleasure to be here, and I want to appreciate the partnership of the two levels of the government. With the support of the development partners, it's been good, and it should be deepened because of the positive outcomes we can see. A good day it is that we have a strong foundation, framework that henceforth will guide implementation of primary health care and will be a catalytic, will have a catalytic effect in achieving universal health coverage. Many people have talked here, but I just want to strengthen what they've said. It's my appeal that we desist from being the Kenyan. We have very good policies and guidelines that gather dust and not implemented. Most of our policies have held different countries. But it's my appeal today that we have all the county directors here. That is a strong indication that we are up to the task and we are ready to ensure that these policies are implemented in the counties. Ladies and gentlemen, I know it has caused us sacrifices in terms of manpower, in terms of financial, and we should ensure that we help demystify the myth that if you want to hide something from Africans, write it in books. So I request and reiterate once more that the county directors who are represented here, let's take time and read these documents. Let us understand the documents word after word. And as it's just been said by Daktari from WHO, let the dissemination be in a good way. Let's not just distribute the policies, but let us have high-level summaries that even a community health volunteer can read and say, wow, this is the policies, these are the new policies. Let us have dissemination also to the sub-counties and even to the facilities so that we all walk the talk together. Thank you so much.
Thank you very much, Daktari. He's a man of action, not words. That's why he left early. But at least encouraging our county directors that we should work together. Now, this is actually where the rubber meets the road. For the next session, I will invite Dr. Andrew Mulwa, who's actually, for us, has been a great privilege for him to come to the ministry level, national level, and more so to head the Directorate of Medical Services, Preventive and Promotive Health. Makweni, where we had put it there, even before thinking about PHC, even after devolution, is one of the counties actually that has done quite well in terms of health services and in devolution. Unfortunately, I will not allow him to give those experiences now. He'll come as a director. We're also glad that he's given us all the support, the space to move in this primary health care. Sometimes I actually just write him an SMS usiku. Now I've seen that we might be jailed, calling our seniors or our employers if we write SMS of our working hours. So I don't know how I will be calling him. So Daktari, karibu sana. We are grateful to have you here. And I will request after this that please invite the guest of honor.
Thank you very much, Dr. Salim. Let's applaud Dr. Salim for work well done. Sometimes it's not easy to stand in these podiums. Many people come here to podiums and they forget their name. So for him to have coordinated that session and those who came before him, thank you. Allow me to take this opportunity to recognize Dr. Kibias, who is the head of the Directorate of Health Standards, Quality and Regulation in the Ministry of Health. Today, standing in for the Director General, Dr. Amoth, our partners present, led by WHO, led by Juliet Nabioga, who has been a real partner in many things that we do together in the Ministry of Health. PATH, the Hennet family in general, AMREF, who we have a long history of working together, both as a ministry and in my previous portfolios, Living Goods, Luala Community Alliance, ALMA, my good friend and classmate, Dr. Angie Vishaga of Financing Alliance for Health, LVCT Health, the World Bank. The bank is here. I saw Dr. Where? Yes. And colleagues from the 47 counties of the Republic of Kenya, led by the chair and my good friend from Homa Bay. Ladies and gentlemen, all protocols observed, good morning. Today is a very, very great day for us in the Ministry of Health because what we are celebrating is a milestone that is founded in the Constitution of Kenya when the drafters of the 2010 Constitution thought about the organization of health in this republic. They divided functions between two levels of government, but in Article 6 said that these functions will be done through coordination, collaboration, and place a very high bidding for health service delivery in the Republic of Kenya. Every time I look at Article 42 of the Constitution of Kenya, where every citizen has the highest attainable standard of health in this republic, sometimes I ask myself questions. Is what we are giving the highest attainable standards? Because as long as it does not meet that threshold, we are not giving Kenyans what the foundation of the Constitution did. I think as a Ministry of Health, our role is to develop policies, guidelines, standards, capacity build counties and emergency care and national referral facilities. I am glad that I've been in the space of devolution from the beginning. And when Dr. Salim was being chased from the counties, I was in the counties. And that was the nature of business then. I have seen the relationships between these two levels of government grow and build working structures, working formula to ensure that documents like the ones that we are about to launch today are developed in a consultative, in an inclusive way, so that when we have the county directors here, we used to have in 2013-14, the debate would be, how did you develop the documents? We were not engaged. But I think we have come of age, and the documents that we are launching here have truly been developed in the spirit of the Constitution of Kenya, engaging both levels of government, which is something as a country we need also to recognize as a milestone and as a way forward in the governance of health this week. It's also a very exciting moment to be in the health space in the Republic of Kenya. I think for the almost 60 years that Kenya has been independent, I think these last 5-10 years have been very interesting in terms of the political leadership and commitment of the leadership to delivery of health to the citizens of this republic. I remember when I was in medical school, a professor used to say, I wish one day health would get the priority to the priority of the leadership of the country. As the Ministry of Health and our partners who work in health sector, that moment is here. In fact, I sometimes feel we are unable to measure the expectations of the leadership of this country in terms of what His Excellency the President, the Cabinet Secretary have committed to deliver to Kenyans, to deliver UHC by the end of 2022. Ladies and gentlemen, it is 2022. His Excellency the President launched UHC this week, and he expects by the time August comes, every citizen of the Republic of Kenya will have access to quality health without incurring catastrophic health expenditure or without cost being not being part. That cannot be done without a proper and functional primary health care system. That's why the documents that we are launching today are very, very critical. A building is as strong as the foundation. The foundation for UHC in Kenya is primary health care. And it is in that that we need to invest in. It is in that that we need to resource. It is in that that we need to continuously monitor so that we ensure that we deliver health for all the citizens of this country. Having said that, and because Dr. Kibias is standing in for my boss, and I was supposed to make very quick remarks as I invite him as the chief guest, I think I want to end it here. The responsibility of implementing these documents is bestowed upon the county governments. I have been in that space as well for a long time. And I think it's time, even us as a ministry, we ask ourselves, beyond the county directors of health, the CECs, the chief officers, the sub-county health management team, who are the other critical players that we need to engage? I feel we have not engaged the members of county assemblies enough to justify resourcing of health, especially primary health care. If we do not bring the MCAs on board and speak to them, to their let me, for lack of a better word, speak to their selfish interests. Their politicians seek political influence. That's why an MCA would rather do a bridge or a facility than to resource a community health unit. But if we speak to their interest and tell them, we will build the network that you will use in your next campaign, you will get the money. We must be innovative. We must ask ourselves, how are we able to convince them so that they start supporting community health and primary health care services? It is important. I feel we have not done enough, and I think that is the next sphere. And working with the counties as we disseminate these documents, I think there is an opportunity of engaging them even more. With those many remarks, it's now my humble pleasure and honor to invite Dr. Simon Kibias to make keynote speech on behalf of the Director General. I was born and I was a member of the Kenya-AFYA National Union, KANU, na tulikuwa tunakaribisha watu na makofi. Let's invite Dr. Kibias with makofi ya KANU. 1, 2, 3. Welcome, Daktari.
Thank you so much, Dr. Andrew Mulwa, my colleague, who is also the acting head directorate of medical services, preventive and promotive services. I really would like to congratulate my colleague for a job well done. I think we need to give him 3 claps, isn't it? Thank you. 1, 2, 3. You have done very well, Daktari, your directorate, for delivering all these documents and making sure that primary healthcare is working. I would also like to appreciate the speakers that have come before us. They have told us what has happened on the ground, especially those from the counties, Garissa and Migori. I think I've been there. I was there in Migori. Thank you so much for the testimony. What we have heard from the speakers is a clear testimony to all of us that primary health care is working and it is being implemented, and that is what will deliver our universal health coverage, leaving no one behind. I think that is something Kenya needs to be happy with at this time. And all of us here present today, we are really privileged and happy to be here at this time to witness this great milestone happening to us. And I think it's a reason for us to be very happy today that we have had real time about the successes in primary health care, and that we are going to witness the launch of documents that will be a living testimony that Kenya is committed to implementing primary health care so that the universal health coverage can be delivered to all and leaving none behind. I'd like to recognize the presence of the following: the county directors of health from the counties, the COG representatives, the senior Ministry of Health officials, led by Dr. Andrew Mulwa, Dr. Salim, the head of Department of Primary Health Care, the Dr. Ilago, Dr. Maureen Kimani, Dr. Gladys Mugambi. I also would like to recognize the partners present today, the WHO representative, Dr. Juliet Nabionga, UNICEF. I also would like to recognize PATH representative present here, HAMREF, represented here by my colleague, my alumnus, Dr. Meshak Ndirangu, ENET Vice Chair, Dr. Thomas, represented here by Dr. Thomas Onyango, who is Living Goods Executive Director. I would also like to recognize Executive Director of LVCT, Liverpool VCT, Dr. Lilian Otiso. And I would also like to recognize all other respectable guests present today. I'm here today to represent the Director General for Health, Dr. Patrick Hamoth, who is also the Executive Chair, who is the Chair of the Executive Board of the WHO. I thought I should mention that. Again. That's something we should be proud of, isn't it? I'm also personally, I thank God for this moment in time that I'm here representing the Director General, and I get this opportunity to thank the government, the top management of the ministry, for this opportunity to preside over this event that is a clear testimony to all of us, like I said earlier, that primary health care is working, is going to work, is going to deliver on UHC, the much anticipated UHC, isn't it? Are we in doubt? No. So we've seen the frameworks. And I think most of us have had the opportunity to work with very many of you, and it had been doubting as to how it will is going to be implemented. But for the first time today, we are having the primary healthcare framework being demonstrated that it is possible to work. And that means UHC is going to be a reality. It's not going to be documents that will gather dust in the shelves. I think it's upon us to make a change going forward from here so that it's no longer theory and theory. I've had the same challenges myself because I've been here for a while. Allow me to say this before I read the speech from the DG. We developed the primary healthcare, we had a primary healthcare department. We didn't go far. I'm happy Dr. Salim has done a lot. Thank you, Dr. We developed referral strategies. Yes. We very beautiful document there, referral strategies 2014-18. It gathered a lot of dust. So when we were developing referral for Nairobi NMS, I was called. Why was I called to participate? I had the institutional memory. Yeah? Because I could remember a few things. But I had nothing to show that it worked very well. We did the emergency medical care policy, but it did not hit the ground. I'm happy it is being mentioned here. And as we speak, there is an emergency medical care policy for Kenya, the first one. And there is an emergency medical care bill in the works. So things are happening. Yeah? So I would like also to reassure you, just before I read the message from the DG, that for the first time, the quality of care and the patient, who is the client, is going to be put at the center of the service delivery. Yeah? For a long time, we've been hearing it being mentioned theoretically, but now we hear it more practically. And why am I saying that? Because the document there on social accountability will ensure that the client, the recipient of service,
the primary healthcare services, the more than 10 packages we were told, will be delivered, and the community will have a say as to the kind of quality of care you'll be giving them, isn't it? They will be able to participate in giving feedback. You received this much, and you have given us this much. They will be able to question at the lower level, at the CHU level, and we are happy that these documents are are going to provide the guidelines to the community health committees on the ground. I'm also happy to inform you that they have reassured us that the Kenya Quality Model for Health, which is the standard tool that we are using in our health system, is going to also be implemented at level 1, at the community level. That's good news. So thank you again to the Directorate and the Department of Primary Healthcare for ensuring that quality is at the center of the service delivery in primary healthcare. And there is nothing that can make us very happy more than that. And you have gone ahead to develop the guidelines on social accountability. Social accountability has been something unheard of. Yes, people bring in commodities, HPTS, in a lorry at night, and the lorry leaves before anybody sees it. I hope this time the goods will be received by the committee chair, and they will be inspecting them now and then. So thank you for that. And without spending much of your time now, kindly allow me to read the message from our Director General for Health on this day when you are launching the primary healthcare documents here in Safari Park. Ladies and gentlemen, the Ministry of Health is alive to the global commitment on primary healthcare. Primary healthcare is all about caring for people rather than simply waiting to treat specific diseases. As earlier envisioned in the Halmata Declaration and reaffirmation at Astana in 2018, primary healthcare emphasizes availing the basic package of essential health services and products required to promote health, prevent diseases, and manage illness closest to those who need them. Ladies and gentlemen, health is a fundamental right embedded in the Constitution of Kenya. Primary health care will cover about 80% of an individual's health needs during their life course. At its heart, primary health care is about preempting care for people and having a focus on prevention rather than simply treating specific diseases. Primary health care is the most effective way to solve health systems challenges, since it extends far beyond just managing illnesses, but begins with embracing health promotion and disease prevention, and considers all social determinants of health. Strengthening primary health care is therefore a key strategy towards attainment of universal health coverage in Kenya. Ladies and gentlemen, primary healthcare networks can support our healthcare system through engaging communities and giving them a voice in the healthcare services they receive, linking them to facilities that are supportive to keeping them healthy, preventing disease, and managing emergencies through fast referral. The journey of establishing primary care networks will improve the overall operational efficiency of the primary healthcare system through providing care in the community as well as in the primary healthcare facilities. The coherence of the hub and spoke model shall address not only individual and family health needs, but also the broader issue of public health and the needs of defined population at large. Ladies and gentlemen, the advocacy, communication, and communication engagement framework for primary health care targets both internal and external stakeholders with a view of increasing awareness and getting buy-in on the need to support and prioritize primary health care. The advocacy community communication engagement framework recognizes the need for multi-sectoral collaboration and will help create the linkage, knowledge, and awareness of health and its enablers at all levels in primary health care. Ladies and gentlemen, the Ministry of Health realizes the importance of supporting and sustaining the provision of quality services at the community level by investing in a credible, committed, and community-based workforce. Key among the community health workforce are the community health volunteers, who are as the frontline health service providers at the household level and the community at large. The community health volunteers are selected through a public meeting and entrusted with the responsibility of health of the community members. Upon selection, the volunteers undergo basic training to gain experience that allow them to provide promotive and preventive services at the household level. The training and certification of the CHVs will lead to a dedicated, well-aligned workforce at the community level. This CHV training and certification guideline will ensure that the CHV training meets a set standard and that the CHV acquire the necessary competencies to deliver services to the households. Ladies and gentlemen, in order to improve communities' health outcomes, we need to build the capacity of individuals and households to know and create demand for equitable and good quality health care. The Ministry of Health is committed to ensure that social accountability of quality of health service will be implemented through the community scorecard. This community-led governance tool will bring primary health care facilities, local government structures, and the community together to promote action, accountability, and responsiveness of their health needs. Ladies and gentlemen, Community Health Committee is the governance structure for community health unit. Community health committees provide an appropriate and supportive social environment for the work of community health volunteers. The Community Health Committee will be required to take responsibility in leadership, governance, oversight, and coordination at the community level. The Ministry of Health is confident that the training of CHCs will add value to the implementation of community health strategy, which provides a robust foundation for healthcare delivery in Kenya. These guidelines lay a framework on which we can enhance our efforts to improve access to primary healthcare services in Kenya for Kenyans. Successful implementation of these policy documents will create awareness for engaging with communities in improving their health, allowing multi-sectoral involvement, as well as tailor effective communication on preventive and promotive health. As I conclude, I wish to call on all of us to support their implementation in whichever way we can. As communities that need this care, as health providers, as implementing and development partners, and as county and national governments. It is therefore my pleasure to launch the following documents: Primary Healthcare Network Guidelines, the Advocacy, Communication, and Community Engagement Framework for Primary Healthcare in Kenya, the Community Health Volunteers Training and Certification Guidelines, the Community Scorecard for Social Accountability for Primary Health Care, the Community Health Committee Training Curriculum, the Community Master Community Health Unit List, MCHUL, Implementation Guidelines, and community health roadmap. I thank you all. Thank you so much. I think that's what is in the message of the Director General, and God bless.
Thank you very much, Dr. I will request you to remain there as they bring the table in front so that we can actually have a celebrative way of launching the documents. Because when Dr. was thanking the team, he said the ladies in the team, he forgot me, so I'll call the powerful girls to come and lead him in launching the documents. Dr. Morin, Gladys, Alago, Dr. Kibias, Dr. Andrew, tafadhali, karibu. Please, our esteemed partners, karibuni. Tafadhali tuje tumsaidie daktari. Okay.
Sorry.
Na mimi nataka kumwaga
Sorry.
hizi.
Wacha apandishe hiyo.
When it comes to decorations, that's where I get lost. So Gladys, tafadhali nisaidie hapo. Yeah.
Oh, ndio usimwage huko nje. Ile kubwa iko pale. Ile mengi utapiga.
And we shall have the community health roadmap. Primary healthcare guidelines. The ACCE advocacy community.
That's what's still. Still. Wamesema tutoe kidogo. Okay, so.
Where? No. You not finish them. Gladys. Gladys. Gladys.
Asanteni sana, asanteni sana. Now we'll have a very short plenary session, maybe 1 or 2 comments, especially that are leading towards how we can implement. I think this will be very important so that we can all be focused on our next steps, especially our way forward in terms of how can we work together and disseminate. For me, more importantly, the issue of dissemination has been mentioned here severally, so that we are not just distributing the documents. Some of the ways that we can have, so that we actually disseminate this document. I think this is very important between the national and the county level. If there'll be a suggestion, you know how we do it, going to the county leadership, we talk to them in a hotel or a conference room, then we disappear. We might need to improve on the same. So for me, this plenary is for us to get some of the ways we can actually implement these documents. So I will invite both people physically in attendance here and virtually, if there are any comments that we can actually enable or improve on our rolling out and implementing this document. So, karibuni. Maswali yoyote, comments zote, yoyote? Yes, Mike.
Say that for a good time, we are now agreeing to focus on the consumer of health services, that indeed, for most of the time, we have always known health system as only about the 6 building blocks, which in Kenya we were able to, revise them to 8, but then still even within the 8, we were not finding the consumer at the center of this service delivery. And so as we launch the documents, the 5 documents on primary health care, we are seeing the consumer being put at the center. And this occasionally, or sometimes we call it the human-centered design of giving service delivery to our people. Now, one friend of mine also, on behalf of the Director General, that human resource is going to be quite primary in terms of delivering what is contained in these documents. And we've talked about the CHVs, but besides the CHV, we are having the mainstream healthcare workers. And really digest, Dr. Salim. We are talking about PCNs, and we have begun to implement this thing in Homa Bay. And one of the issues that arise, the community who are the catchment population within the hub up there find it very unpopular for them to be asked not to access, and they say, our own hospital, which in this scenario has been elevated. For example, in our counties, we are having sub-county hospitals. Apart from the county referral hospital, we have sub-county hospitals which have been marked as the hubs. And so the community around that catchment area for the hub, they don't want to see that facility as not for primary care. They want to see it as, if you feel unwell, you should go there, just walk straight. And so one of the things that we need to agree is whether within the hubs, we are also going to have some departmental, some aside unit that would provide PHC, you see? So that we are having that structure, we were able to see the flow that is envisioned in this. What are we thinking about as a team, especially for the catchment areas of the facilities that are referrals, the facilities that have been marked as hubs, what do we think about? So with that, maybe we can discuss that and also agree on what needs to be done. Thank you. I appreciate this. This is at the nerves of my own system. I'm very happy. Thank you.
Thank you very much, Daktari. Have some few announcements. One, please, county directors, the National Vaccine Immunization Program is requesting for you guys to wait. They're coming. They have your fuel cards that they want to give you for the campaign. Then there is a desk for you to sign for your allowances. Last but not least, there is good lunch. Any other input? We have taken that, Dr. Yes, Mike here, and then behind there. Mike in the front. Somebody could be please checking virtually, just that we do not miss them.
Good morning, everyone, and congratulations on the launch of the primary healthcare strategic documents. I work in Gatundu South Sub-County as the MOH, and I have been involved in primary healthcare. And what I'd like to say is, going forward, when we have, for example, new pandemics that we're dealing with, new diseases that we're dealing with, we need to make sure primary healthcare remains the cornerstone of addressing these new diseases. Because if you think about it, when we had COVID, we realigned our healthcare system to focus on COVID and fragmented our healthcare system. But what did we need to do? We needed to strengthen primary healthcare when we were dealing with COVID-19. Isn't it true? Yes. So even going forward, as we're dealing with vaccination for COVID, it should actually be part of our primary healthcare mandate and should not be something separate from primary healthcare. So I think that's one of the ways in which we can ensure that this strategic document is implemented, by taking over all the activities that fall under primary healthcare and ensuring that we don't fragment it into disease-centered approaches. Thank you.
Thank you very much, Dr. I think that's a practical example down there what we should do. Right, not fragment or spoil or reduce the other one so that they can be complementary. Thank you very much, Dr. There's a hand behind. So my team, hopefully you are jotting down the issues, the comments, and suggestions.
Yeah, once again, my name is Kakuri Richard. I'm the Acting Director, Public Health, West Pokot County. Dr. Salim, I want to thank you so much, sir, for this launch. In fact, it's long overdue, and I want to thank you so much. I know you are not sleeping with your team, and I want also to thank Mr. Wanyungu and others who really worked on this. First, I want to say that personally, I'm giving an example of West Pokot County. It is hard to believe that even West Pokot, from one health facility to another, is more than 10 kilometers. While when you go to WHO, it's around 5 kilometers apart. And when you look at all these facilities, I don't want to go back to what my brother said, the first speaker, about one staff in one health facility. And the PSN looks at a comprehensive teamwork, where we are talking of multidisciplinary. It requires that we have people from agriculture. If it means a borehole, then we look at a borehole in a wider perspective. We look also to have a Ministry of Agriculture or Water. At the same time, we need to have other people in it. I don't know whether the package for supporting this is available. That's one. Two is about employment of more health staff. As we are aware, like my terrain of West Pokot, there are places which are hard to reach. And when I mean hard to reach, there are places you cannot travel a day and reach. For example, when you are in Pokot North, you travel the whole day, then tomorrow you reach the facility. And probably when there is a capacity building meeting or call meeting which is a training for health workers, it means the whole facility must be closed. I don't know how is it going to happen. We were looking at times if we can be able to get a guideline. We advise the county government, because currently we have been trying to talk with these CECs, the chief officers. You know, they are not health-oriented people. These are political heads appointed. And when we give our own, we have been having challenges for the last around 10 years since devolution came in. There is no success. We've tried to talk this, then they are doing their own things when it comes to administrative. So I wanted to request if, because at national you normally deal with the policies, now the guidelines, the way we are, I'm very happy with this document, only if it is implemented. I want to say that we have tried the other part of engagement of MCS for policies. We have a CHS Act, that's Community Health Service Act, which is already in place but not implemented because lack of resources. And we were requesting that if a national government, through the Ministry of Health, can assist us, through COG again, if they can assist us, because having the act is not enough. It needs to be implemented. The CHVs are supposed to get some stipend according to that CHS Act. We have already done restructuring as a county. We have around 226 CUs, or community health units. But training of these CHBs on basic package needs some partnership. In our county, we have a shortfall of the same. But we want to thank the UNICEF and appreciate them so much. They have done us proud. In fact, around 800 CHVs have been trained on basic package. And we need to train, we have around 2,400, of which they are not trained. So around 1,300 are not trained. Thank you so much.
Thank you. Anybody online? Technicians? Uko virtually, hawana maswali, wako sawa, hawana comments. Hapa tuko sawa. We are ready for lunch. Asanteni. So next program was vote of thanks. So one and foremost, so something from the Society of Community Health Caregivers. This is a good progress indeed, although we urge you to reach us, especially the people who are on the ground, the CHWs, the chairs and chores. Dr. Kimani, that is for you. Kindly consider reviewing community health curriculum from CHWs to chairs to chores. More primary health care knowledge is needed. We shall appreciate. Kindly integrate community health into the healthcare system, more so in the Health Act for efficient delivery of primary health care. Kenya Health Act has clearly defined that community health is level 1. So we don't need to integrate it. In the Kenya Health Act 2017, it is very clear in the document that community health level is level 1. It talks about the functions and who is even in charge. Yeah, I think those are the comments I'm reading from here. So I was saying, if there are no more inputs, comments, I can go to the last part of our session before we go for lunch. Hopefully the directors, people from the county who are outside, they heard what I said. The national vaccine immunization program is coming with their fuel cards for the campaign, and they also need to register for them to be able to be paid their allowances. One and foremost, I want to thank the Almighty for enabling us to gather here and finish this function well. I want also to thank the representative of the DG, that is Dr. Simon Kibias, who was here. He's a great support to us in the area of standards. I want to thank our director, Dr. Andrew Mulwa, who is really, since he came, given us a lot of support and input for us to implement in this area of primary health care services. I'm very grateful to Dr. Juliet Nabianga, the WHO WR, who was here, for their commitment, the support they've been giving us, technical support, and the focus currently also in WHO on community health. I want to thank Dr. Gordon Okomo, the chair of the County Directors of Health, for his support and also directing, encouraging the other county directors to be committed in this implementation of these documents. I want to thank all the senior government officials, both at national and county level, who are here and have been supporting us. I want to thank the team really who have been working with us to support this to materialize. World Bank included, UNICEF, we are grateful, Rose Njeraini, for the support path leading us to this, supporting this conference. Living Goods, J&J Foundation, especially Anthony Gitao, who has been here, Caroline Juguna from Perth, Dr. Meshak Ndirangu, Amref, the chair of HENET, Mr. Thomas, who is also the country CEO of Living Goods, all the partners in the community health units for UHC, including Living Goods, Luala, Community Alliance, Amref, Working for Health, Think Well, the World Bank, especially for me, World Bank has intention to support some counties under the THS program to implement primary health care. I'm also very grateful to UNICEF. Besides supporting Garissa for the next 3 years, now has started supporting Kisumu, implementing the primary health care network. They also have identified other 4, I think Elgeyo Marakwet, Turkana, Samburu, included there. So we are grateful, UNICEF, for the support of implementation of the primary health care networks. Our colleagues attending virtually, we don't take you for granted, spending your time with us and availing yourself. We are very grateful. All the partners present, we are grateful for you. For the directors, I really want to say shukuru sana. I know currently it was a very difficult time for you guys to get out of your counties. There is several things, especially more so the COVID vaccination campaign that is going on, and it has actually been extended by the national level. I really want to thank my team in the primary health care who have been working day and night to see this to become a reality. The Fourth Estate, asanteni sana Kokuja. We hope and believe that this message will be taken outside there so that we can have more partnership, synergy, so that we can implement this at the county level. Asanteni sana, tumeshukuru. Nani atatuombea kabla tuende kula? Any person who is feeling prayerful? Karibu.
Thank you. Ladies and gentlemen, let us rise and we pray. In the name of the Father, the Son, and the Holy Ghost, we sincerely thank you for the day. We thank you for the session that has gone. We thank you, Lord, that you have led us in all deliberations. We thank you for giving guide in the launch of PHC documents. We thank you all for the leadership. All members that have been here, Lord, you have given them guide. We are now leaving to our various counties. We commit ourselves before you, and we pray for journey mercies, that if when we reach safely in our various counties, we shall lift your name high. Thank you for the partners, that they are supporting us as the ministry to deliver and support communities all around Kenya. We pray that, Lord, as partners stand, supporters, you shall stand along with them. We commit for the leadership in the ministry. We commit Dr. Salim before you, that, Lord, is looking for ways and resources to support PHC in Kenya. And Lord, we pray that you shall bless him, bless his families, bless also those ones who are leading divisions, and also bless the whole leadership of the Ministry of Health. We thank you, Lord, that we have partners that we have not remembered in our prayer, that partners all over and the media are supporting us and hence our health services. We thank you, Lord, for those ones who have attended this meeting virtually, that they have also gained and they shall support others elsewhere. We thank you, Lord, for the answer that you shall give us as we endeavor to support the communities that you have put in our hands. Thank you, Lord, for the answer, and in Jesus' name I pray and believe.
Good. Usimame aje. You know, there's somebody over there on TV who's taking me. Ah, Moha. Umechukua? You're done. But I want her to take a proper camera. She'll send you. So she'll tell me how to stand or where to stand. How do I stand? Alois!
Whether you are leave or not, it will be